Hello everyone, welcome back to my channel. Today I am going to discuss part 3 of mouth preparation in complete denture. We have already discussed part 1 and part 2 of mouth preparation in complete denture. If you are not watched that video, then please watch that video. Okay. So we have already discussed that the surgical methods are soft tissue procedures and hard tissue procedures. So the soft tissue and hard tissue procedures have been discussed earlier. Today we are going to discuss secondary hard tissue procedures and secondary soft tissue procedures. So the secondary hard tissue procedures may involve ridge augmentation and ridge relationship alterations, and the secondary soft tissue procedures include vestibuloplasty. Here it is a panoramic screening to evaluate the bony topography of a patient with atrophied jaws. So this is the picture showing a panoramic screening or panoramic radiograph, which is to evaluate the bony topography of a patient with atrophied jaws. And this picture is a lateral cephalometric radiograph, which will give an accurate representation of the amount and orientation of the remaining bone, especially in the anterior region. So coming to the vestibuloplasty, according to GPT-9, it is a surgical procedure designed to increase the effective residual ridge height by lowering muscles attaching to the buccal, labial and lingual aspects of the jaws. And its purpose is to obtain more denture extension, reposition the muscle attachment to obtain better support for the prosthesis. So the vestibuloplasties can be grouped into three basic techniques. They are mucosal advancement, secondary epithelialization, and those using epithelial graft. Can be done using, so first one is mucosal advancement. That is the subepithelial connective tissue which is dissected and repositioned apically with the aid of a surgical stent. It is mostly used in maxilla. It has potential for relapse. And this procedure was put forward by McIntosh and Obwexer in 1967. Second procedure is the secondary epithelialization. Here, an apically repositioned flap which is featured to the periosteum at the desired depth. The area is allowed to heal by secondary intention. Overcorrection is usually necessary as there is 50% relapse. And the hyperplastic and hypermobile tissues can be reduced at the same time. Coming to epithelial graft vestibuloplasty, a skin or oral mucous membrane graft is used to cover the exposed tissue following raising of a full thickness mucoperiosteal flap. And it is allowed to heal by primary intention. And this is the most successful method of vestibuloplasty. So, epithelial graft vestibuloplasty is the most successful method. And Esser in 1917 first described this technique, and it was later developed by Obwexer in 1967. In the first picture, it shows the advanced. Here, there are two pictures. It shows the advanced anterior mandibular residual ridge reduction, which leads to mentalis muscles origin ending up close to the ridge crest. In part A, it's shown that residual vertical height would lend itself to a sulcus deepening procedure to allow scope for an enlarged acrylic resin base at this site. And in part B, on the other hand, it would be a candidate for onlay graft given the short height of the residual mandibular site. And this picture shows the sulcus deepening procedure. Here it requires surgical detachment. So in this picture, it shows the from pictures A to C, it shows the sulcus deepening procedure requires surgical detachment of labial and buccal muscle attachments followed by placement of mucosal or skin graft. While this approach yields a larger available area for acrylic resin coverage, it also risks so-called witch chin appearance. Here It is the acrylic resin coverage. Here this large available area for the acrylic resin coverage. And so it is known as witch chin appearance as a result of localized altered morphology and muscle function. So in this picture it shows witch chin appearance. Okay. So the chin of the witch appearance is shown in this picture due to the large available area for the acrylic resin coverage. Okay. So from pictures A to C, it shows the sulcus deepening procedure which requires surgical detachment of labial and buccal muscle attachments, followed by placement of a mucosal or skin graft. Okay. And in this picture, it shows the outcome is equally evident when a more extensive sulcus deepening is carried out. That is from the figures F to H. Okay. So from this picture, that is IJK. Here, it shows the edentulous maxilla. The procedure is less frequently prescribed for edentulous maxilla. And all of these pre-prosthetic surgical procedures have now been virtually eclipsed by routine implant placement and advances in bone grafting combined with implant prescriptions. So that is about all about the sulcus deepening procedure, okay, or vestibuloplasty. Okay. Coming to ridge augmentation procedures, according to GPT-9, ridge augmentation is defined as any procedure designed to enlarge or increase the size, extent, or quality of a deformed residual ridge. And augmentation by bone graft which adds strength to extremely deficient mandible or maxilla, and it improves the height and contour of the available bone. Autogenous graft from iliac or rib soles are the most biologically acceptable, but they require additional extensive surgery at the donor site. So use of an hydroxyapatite alloplastic material which eliminates the donor site surgery, but it poses some problems of resorption. Okay. So currently the graft have been combined with osseo-integrated implants and have shown promising results also. Okay. So the bone grafts or alloplastic materials are used to increase the size of an atrophic alveolar ridge. So the most commonly used techniques for ridge augmentation include visceral osteotomy and onlay bone grafting. So in this picture, it shows ridge augmentation by means of an alloplastic material. Okay, in these two pictures. Okay, or a homologous graft in the picture C. So in the pictures A and B, here it uses alloplastic material, and in the picture C it is a homologous graft. Okay, it has been eclipsed by combinations of autologous bone grafting and implant placement. However, only bone grafts cannot be used for increasing the height. Thus, distraction osteogenesis is the only option in such cases. So coming to the distraction osteogenesis, according to GPT-9, it is a procedure whereby a segment of the jaw is sectioned by osteotomy and gradually displaced by controlled movements to increase the height of the edentulous ridge. Okay, so it is also termed as calotasis or callus distraction or osteodistraction. It is a surgical technique of generating new bone by progressive stretching of the divided bone segments. It was invented by a Russian surgeon, Dr. Gavril Ilizarov, who used the procedure to treat the problems of the leg. And the procedure is used to increase the height of the bone in resorbed ridges. In this picture, it shows the distraction osteogenesis. In the picture A, here the distractor is placed in a resorbed bone. And in the picture B, here the distractor is activated and formation of new bone occurs. And in the picture C, maturation of newly formed bone shows. Here it is the increased height of alveolar bone. Okay. So these are the phases of distraction osteogenesis. Latency period. Here the hematoma formation occurs following osteotomy, which is later replaced by granulation tissue. In the picture B, it is distraction period. Here the bone gap is progressively increased with osteogenesis at the margin of distraction gap. In the picture C, it shows osteogenesis extend to the center of the gap during consolidation phase. In the picture D, it shows maturation of the ossification in the distraction chamber in late consolidation period. And in the picture E, bone remodeling and continuity of alveolar canal after completion of distraction osteogenesis. So these are the phases of distraction osteogenesis. Here it is the surgical simulation of distraction osteogenesis procedure using stereolithographic model for craniofacial distraction in anteroposterior direction. So these are the various, here there are various markings. So red line marking indicates planned osteotomy line. And in the picture B, it shows placement of internal devices at the zygoma area bilaterally parallel in the horizontal plane. Okay, zygoma area bilaterally parallel in the horizontal plane. In the picture C, distraction stimulation on STL model to confirm direction and final position. And the picture D, placement of external device to distribute the distraction forces equally to supraorbital and maxillary region, therefore increasing the distraction stability. Okay. So finally, by concluding the mouth preparation, it is an important step before we commence the construction of complete denture processes. Examination of hard and soft tissues of the oral cavity will provide information about the need for pre-prosthetic mouth preparation. And the preparation may also be essential in existing denture wearers due to tissue abuse. Most often, it may be necessary for the patient to abstain from wearing the denture for at least a period of 48 hours before we start the impression procedures. Okay, that's all about the mouth preparation in complete denture in detail. And thanks for watching. And I wish all my dear viewers a very happy and prosperous New Year 2021. Thank you.